patient progressed after 3 months of being on lenvatinib, and if we look back at a lenvatinib phase 3 study, we have to appreciate the fact that patients with Child-Pugh B were not included in this study. It was one of the exclusion criteria, so we really don't have a good idea about response rates and time to progression of patients under Child-Pugh B category on lenvatinib. However, the patient progressed at 3 months, and that triggered the next question, which is what to do next. So this is a second-line systemic therapy after lenvatinib. If we follow the current guidelines, actually all of the drugs approved in second-line setting were done following sorafenib, with the exception of one study, cabozantinib phase 3 study, that allowed 2+ prior systemic therapies. So for this patient, he went through lenvatinib, and then his treating physicians decided to embark on immunotherapy with nivolumab. So that takes us to another question, which is sequencing of therapies and FDA approval status and insurance approval status, which is very relevant to community physicians given the lack of access to a large number of trials as compared to academic centers. So agents in second-line setting for HCC were approved after sorafenib failure. So most of the insurance carriers and also the FDA labels and indications specify progression on sorafenib. Lenvatinib came to the picture after the non-inferiority study reached its primary endpoint. The lenvatinib now is undergoing evaluation for this very specific question about sequencing to address this issue. Until then, it may be a challenge sometimes to some patients and their treating physicians to get second-line drugs approved after lenvatinib progression. However, most of the time, with the appropriate appeal process and physician to physician, these issues are always resolved. So nivolumab immunotherapy was approved after progression on sorafenib. This study actually included some Child-Pugh B patients, B7 score, and that's also part of the indication and included in the FDA indication and HCC guidelines. The patient was treated with nivolumab for about 3 months and then underwent a scan that showed further progression after the patient clinically also experienced increased fatigue. So this is what we call clinical and imaging progression. So the question now will be a third-line option for this patient, which is not uncommon nowadays, especially in patients with good performance status and stable liver function status. This patient remained in Child-Pugh B, however, was stable. There was no deterioration, further deterioration of his liver function status, and ECOG performance status remained stable. So it really reflects a real-life scenario of patients managed in community settings by primary oncologists who are seeing a lot of patients with concomitant disease, underlying liver disease, in addition to HCC, what we call two-disease state. So those patients, as long as they have good performance status and bilirubin is also stable over time, and this patient was always hovering around 3, they continued systemic therapy for this patient. This is not a typical case scenario where you have Child-Pugh A, but it is a scenario that community oncologists face all the time, and they manage patients based on multidisciplinary approach and a consensus, especially patients in good performance status and stable Child-Pugh B, but stable disease with frequent monitoring. So in my practice, if I have a patient in these shoes, in general, we manage it in a multidisciplinary setting. So upfront, before embarking on localized therapies, we have to assess risk-benefit ratio. And if the patient at high risk of liver deterioration and we don't expect a high chance of response to local therapy, we start with systemic therapy, and then based on the liver function status, we tailor the dose of the therapy. Sometimes we start with lower dose for a couple of weeks to build up tolerance. So all of these approaches are based on multidisciplinary approach and based on the expertise of the treating team. And a lot of times, once you go through lower dose upfront, build up tolerance, patients tolerate it better than starting with higher dose. There are some studies and trials looking into that, to look into lower dose of TKIs, increasing it over time rather than the other way around, which is starting with higher dose and then lowering it down according to tolerance. So these are differences based on specific individual practices and local expertise. So in this current era of hepatocellular carcinoma management, there is a momentum for immunotherapy, and based on this momentum and signals of activity with single agent checkpoint inhibitors such as nivolumab and pembrolizumab, they were approved in the last couple of years based on single arm phase 2 trials, and they were granted conditional approval by the FDA. However, the randomized studies for both agents, pembrolizumab in second line against placebo and nivolumab in front line against sorafenib, did not reach their primary endpoints, so it was a setback for single agent drugs in HCC when it comes to immunotherapy. However, both studies, initially the phase 2 studies and also phase 3, are showing some signal of activity in select patients. We don't yet know what kind of patients are expected preemptively before starting therapy to do well with immunotherapy. So in general, just like any other systemic therapy, we follow guidelines in terms of starting therapy and then following patients clinically. And then in terms of the frequency of the imaging, some clinical trials put it at 6 weeks, others put it at 8 weeks and even 12 weeks. So in routine practice, we go by clinical condition as well as imaging to assess response to therapy. So in patients who are clinically deteriorating, we tend to get the scans earlier than scheduled, but the average is around 8 weeks to 12 weeks, depending on the specific practice. If the patients are clinically stable, we get re-imaging scans around this range, 8 to 12 weeks, which is generally acceptable. So, but if there is clinical deterioration, we get it sooner. So this patient has got advanced Child-Pugh B, so that could have been one of the contribution factors to lack of response to local therapy and also 2 lines of systemic therapy.